Thanks.
Good afternoon, everyone. My name is Lieutenant Fred Butler, United States Public Health Service, and we welcome Centers for Medicaid and Medicare Services. We appreciate you joining us. Today is our first of two pre-bidders conferences for the Transforming Clinical Practice Initiative, a service delivery innovation model. Today you will be hearing from Dr. Chisra Asmuga, Mrs. Jean Moody Williams, Dr. Paul McGann, Dr. Dennis Wagner, Ms. Angela Rivera. Following this, we will be able to have an opportunity for individuals to enter questions online prior to us closing. At this time, I'd like to turn the call and our pre-bidders conference to Mrs. Jean Moody Williams. I apologize. We'll go to Dr. Chisra?
Good afternoon, everyone. I hope you can hear me. We are, like Lieutenant Butler said, beginning the pre-bidders conference for PTNs. On our next slide, you will see that if you have any questions, we would like for you to type those questions into the chat box. This is very important to us. We know what you guys are thinking and know how to inform our answers and responses going forward. For those of you that are live streaming right now via YouTube, you want to email your questions to transformation@cms.hhs.gov. Again, that's transformation@cms.hhs.gov. The answers to your questions will be posted on the Centers for Medicare and Medicaid Innovation, that's the Innovation Center website, and more detailed information related to this opportunity that we'll be speaking about today can be found on the funding opportunity announcement located on the Innovation Center website as well as grants.gov. Again, that's on the Innovation Center website and on grants.gov. So shifting gears, I want to talk a little bit about the context for transforming clinical practice. As you guys are well aware, in 2010, the passage of the Affordable Care Act renewed efforts to improve the system. These efforts have been guided by a focus on what we call the three-part aim: better health care at lower cost through quality improvement. And we know that clinicians across the country want to improve care for their patients and to position practices to thrive in a pay-for-value system, a system that rewards value and quality over frequency. Increasing accountabilities from care delivery reform programs such as the Medicare Shared Savings Program emerged as a result of the Affordable Care Act. And we also knew that about 16%, or approximately 185,000, are currently participating in CMS advanced care delivery models that drive at that three-part aim of better health, better care, and lower cost through quality improvement. But we want to increase that number and make clinicians everywhere have the tools and can engage in shared learning to promote practice transformation, which will allow for us to achieve those three-part aims. Innovation. Successful clinical practice leaders can support their peers with direct technical assistance to help them transform their practices. Now, we know that clinicians or clinician practice leaders have already charted the pathway to practice transformation. On one side in this slide, you'll see the traditional approach where patients arrive to the clinic with a chief complaint or a reason for a visit that determines the kind of care they're going to have. The care is determined by today's problem and the time available today. It varies by scheduled time. Does the doctor remember who the patient is? Does the patient remember who their primary care physician is? All these traditional approaches, as clinicians, we understand aren't always the best advantage. But what does a transformed clinical practice look like? It looks like we are systematically addressing all our patients' health needs to plan care. And care is determined by a proactive plan of professionals who are working to coordinate the patient's care. Clinicians know that they're delivering high quality care because they measure it and make rapid changes to improve. They're constantly getting the feedback to know where they are in terms of the kind of care they're providing, and then are able to adapt accordingly. And then they can track tests, consults after emergency department. They can work with patients and families and have more time to work with patients and families on things that are important to them regarding their health. It's like Secretary Burwell said when she announced this on October 23rd, a couple weeks ago. We all have a stake in achieving these goals and delivering for patients, providers, and taxpayers alike. It really is about all of us in the community of practice making sure that we're working together and learning from each other to drive that three-part aim of better health care at lower costs. So, in clinical practice initiative, there's a couple of points we want to make sure that we discuss. First, it aligns with the criteria for models that was first set forth in the Affordable Care Act. That's promoting broad payment in practice reform, promoting that care coordination I spoke of earlier, establishing community-based health teams to support chronic management, and promote improved quality and cost by creating here through this initiative model is clinician practices through 5 stages of practice through practice transformation, support and alignment networks, quality improvement organizations, and clinicians, because we're all part of this community of practice to make sure we're driving towards that 3-part aim. With that, I'd like to turn it over to Ms. Jean Moody-Williams, who is the Deputy Director for the Center for Clinical Standards at CMS.
Thank you very much, and I really appreciate the quote that you gave from the Secretary about all stakeholders. And you might ask, so what does it really mean when we say we all have a stake? Likely, if you're a clinician, you might be thinking, well, my main stake is to care for the patients that come to me seeking help on a day-to-day basis and to contribute to the health of the community that I serve. You may be thinking what I really need is more time, tools, resources, and payment that support my effort. As you may be able to tell, I've been listening to you as I meet with you throughout the country from clinicians and acknowledge your requests for a more seamless, coordinated, and thoughtful approach to reform. Well, that's exactly what this model is all about. Everyone to achieve transformation and to provide national technical assistance, aligning efforts and resources across the many wonderful programs and models that are currently underway. The second prong provides resources to support peer-to-peer learning and exchange of information through formal practice transformation networks composed of multiple clinicians who have agreed to work to form a learning system that will not only lead to in their practice flow, quality improvement skills, and patient outcomes, but that will also help to shape CMS policy in the future. Lastly, support and alignment networks that will channel their tools and resources to help align requirements and continuing education to move in the same direction that the practice are moving into. Now, this model will assist primary and specialty care clinicians, which includes nurses, physician's assistants, pharmacists, and others. But just as importantly, we are not trying to build silos of care, but those kinds of connections and networks that connect with communities, ambulatory and post-acute care hospitals and healthcare systems, social and public health services, and really the only reason that we're all doing this is to improve the care for patients and families. Now, as we were developing the model and going through our various stages of iterations of clearance and thinking about what we wanted to do, the most frequently asked question that we would receive was, what is it exactly that you're trying to achieve? And you may be asking yourself that very same question. What does success look like? And I think we have addressed that at a high level already throughout this presentation, the specifics. And it really is essential that these goals be understood and addressed as you prepare your proposals. At the end of the day, when it's all said and done, we want to be able to clearly demonstrate that more than 150,000 clinicians have been served by transformation activities. That the Practice Transformation Network, they know who's in their network, how they participated in activities, support clinician needs, and what stages the clinicians are in progressing toward the goal. important goal is that health outcomes have improved for millions of Americans, and that we be able to measure that improvement from baseline to continual trend toward improvement over a measurement period. That we really reduced unnecessary hospitalizations for at least 5 million patients, and these efforts will come, and of course we will measure that reduction as well. And we want to support efforts that are already in the clinic to reduce waste, unnecessary procedures. These things often come about from not being able to get the information that you need, not being able to discuss preferences with patients, not having the best science, and the list goes on. And we want to make sure that when we have progressed through this model, that we've learned something that we can spread to many other clinicians, patients, and families that may not be participating initially in this effort. When we put all of this together, it's going to lead to lower cost, but lower cost through improvement. And we've worked with our actuaries that we believe will generate estimated savings somewhere in the area of $1 to $4 billion. So when we look at who might be a Practice Transformation Network or Support and Alignment Network, we want to be as inclusive as we can be to ensure that clinicians that are willing to partner with a network can participate. For this model, clinicians include primary care, specialty physicians, nurse practitioners, physician assistants, clinical pharmacists, and their respective practices. They can participate. The FOA, the funding announcement, eligibility requirements around this area that we have either already or will be addressing particular issue. But we do, and we also have questions about, well, if I'm in this model, another model, can I participate in this model? And we are addressing that as well. I think the concept here is that we can't duplicate efforts. We want to complement efforts that may be complementary or that can allow, as you're thinking about this, if there's duplicative.
Gene, my name is Paul McGann. I'm an internist geriatrician that works at CMS. And you know, Gene went over the 6 aims of this entire initiative a couple of slides ago, back on slide 8. And we believe here, as we put together, that aims create systems. And we think if you pay attention to these goals in your proposal, that things will come together for you. But as a physician or a clinician out there, a nurse practitioner, physician assistant, you might be asking yourself, that's all well and good for the healthcare system, but what's in it for me? And this slide is for you. If you're out there seeing patients and you're wondering, how can I optimize the best care? We think that participating in this program over 4 years will enable you to do that. We think participating in this program will help connectedness of care for your patients and help in care coordination. We think as you participate in this massive national learning community, you'll be able to learn from your peers and high performers. This isn't about CMS telling people how to do things. It's about CMS facilitating a learning environment where high performers can show others how to actively engage patient and families and other things that characterize the advanced stages that Jean Moody Williams went over. We do believe that as you get engaged with this program and as it goes over time, you'll experience more time spent caring for your patient time on administrative details. We think you'll experience alignment with the new and emerging federal associated with healthcare reform and payment reform all around the country. You'll be really connected to the people and the systems that create these policies and actually have input into them. This will be a real opportunity for those of you place in this to be part of the national leadership in practice transformation effort. So we think there's a lot in it for you. We look at this slide now, you know, quality improvement and evaluation go hand in hand, and this program has been carefully thought out to focus on measurement and measurement for the purpose of quality improvement. This is not a payment model, delivery model. And the measurement systems that we're going to use here are going to be focused on improving quality. The major are quality of care, utilization of care, cost, patient experience of care. And within those, there will be multiple systems of measures that the PTNs will bring forward. Many of you out there have experience already and have very sophisticated networks of measurement systems that you can bring to this effort. To the extent possible, we're going to be using existing systems to collect and share quality improvement data with the practices. CMS and the evaluation contractors are going to take the quality improvement data from the PTNs in aggregate to guide the national quality improvement work. And you're going to find this very useful as participants because you'll have access to that aggregate data and you'll be able to compare the data in your practice with the data from around the country and the different PTNs. The continuous feedback loops that we in this learning network between the different practices and PTNs are one of the strengths of this project, and we think it will accelerate the pace of learning. Now, a project this big has to be subject to very strict evaluation, and one of the advantages of this project being coordinated is that we have direct access to national meaningful use data, reporting program data, for the new physician value modifier program data, and other clinician or other clinical quality programs and claim and data from other large national systems, including in the QIO program. And all of this data can be used to assess the impact and the progress as we go through the stages of transformation. If you go to the next slide, you'll see that transforming clinical practice designed with sustainable redesign in mind. What does that mean? Well, as I say, this isn't a payment model, it's a service delivery model. Attempting to establish a national collaborative learning network, and it's peer-based, not pushed from the top down. It's the collaborative network learning from one another. We'll develop a learning community of practice together. You'll have an opportunity. We see this as an opportunity for bi-directional learning, so that as you share each other and with CMS and its development of strengthening healthcare policy will learn from your experiences and what you'll be able to teach us. This is really an opportunity to sustain good practice for clinicians involving patients and families long after this project is over and into the future. In the next slide, you'll see some of the details we're going to start to go into now about how this is going to work in the early phases. Phases will have to do an assessment of practices to find out where the practices that are applying are going to start from, and the PTNs and the QIOs are going to help us with this. The initial assessment results are going to be used by the clinician directly mapped to the achievement of the goals that you saw on slide 8. These reassessments are going to be managed by the QIO Improvement Organization Program and the Practice Transformation Networks working in concert. And the assessments are going to be used to determine the clinician and the practice's progress in moving through the phases, and will be based upon the achievement of the quantitative and the qualitative milestones that are outlined within the FOA. They're listed here with the documents. So we're going to be assessing the quality improvement methodologies currently employed by the practice. As Jean noted, many of you are already involved in this type of activity, already with data, and we want to know that at the beginning because you'll be the advanced practices. We want to do assessments of the patient, the clinical results, the effective use of health information tech and related technology for clinical and operational improvement. People in their practices fall on a wide range of spectrums of ability. The initial assessment will be used to figure that out. Team-based care delivery models are also going to be assessed, including roles and services provided by each of the individual team members, and assessment of the current business models, and finally, related financial and administrative practice community linkages. All of these dimensions will be assessed in this initial and ongoing assessment. Now, it's very important, Jean's mentioned this a couple of times, and I'm going to turn it over to my colleague Dennis Wagner now. There are a lot of resources in the community at this point, and it's very important to us that these resources be used in combination and synergy. And the thing we're trying to avoid here is what they call duplication of effort, and Dennis Wagner is going to outline for you what is to assure maximum synergy and harmony as all of these programs work together to achieve the goal.
Great. Thank you very much, Dr. McGann. As Dr. McGann said, my name is Dennis Wagner. I'm delighted to be with you this afternoon for this session. And I want to begin by just thanking you for all the questions that are streaming in live in the chat box. It is our intention to answer all of those questions, post the answers so that everyone can see the answers to everyone's questions. That's the process that we'll be using there. I also want to just confirm, because so many people are saying, please subscribe to this email address or that email address. The slides that are being presented here will be posted. They will be posted on the CMS Innovation Center website at innovation.cms.gov. So you don't have to worry about that, and you don't have to message as part of the chat line here. Your chat line messages on the questions that you would like to see answered about the process and the proposals. So as Dr. McGann had said, preventing duplication of effort is critically important. And the expectation here on the part of CMS is that practice transformation networks will be teaming and working collaboratively with lots of other organizations that are involved or touch on this kind of work. Of examples here on this slide: state innovation models, regional extension centers, CMS quality innovation networks, and organizations. Our expectation is that successful awardees of the Practice Transformation Network will be working with these organizations. Our intention is a full court press alignment across multiple different kinds of organizations who are sending the same kinds of messages platforms, but it's critically important that we're not spending money to do the same work in different organizations. So there is a very specific process that successful networks will be expected to go through to maximize synergy and to prevent duplication of effort. Those folks who are awarded PTN awards will be required to scan the environment, identify other people who are working in this same sphere, meet with those other people, document plans to prevent duplication of effort, synergy, and then share those plans back with your respective federal project officers for affirmation or for change. That's the process that we'll go through to prevent duplication of effort. Now, if we could move to the next slide, this is a question that many people have asked. Can I be both a practice transformation network and a support and alignment network? And the answer is no. You cannot be both, and there is a specific section on the restrictions on award part opportunity announcement that details that more specifically. We could advance to the next slide. You heard earlier from Williams, who outlined some of the kinds of organizations that we think might be a practice transformation network. It is our intention in the design of this initiative to be deliberately broad of the types of organizations that are most likely to be practice transformation networks. The CMS investment in this work is focused principally on practice. You'll see in the funding opportunity announcement, section Roman numeral 3, Arabic number 2, award amount, that our expectation in applicants will generally be applying for a level of funding $1 to $50 million for the 4-year period. And the size of that funding amount would, of course, be linked to the scope and projected impact of your work. Expectation outlined in Roman numeral 3, Arabic number 5 of the funding announcement is that we are likely to make awards of up to 35 cooperative agreements for practice transformation networks. Again, that will be, of course, at the discretion of the government and contingent upon the quality of the we received. Now, if we go to the next slide, so what is the work of practice transformation? And you see on this slide kind of 4 examples of the kind of work that we anticipate practice transformation will be doing and will be accountable for. After this, that gets into even more detail. But I'd like to focus here on the first bullet that you see here. The Transforming Clinical Practice Initiative seeks to have PTN applicants to work on stated aims and related milestones. The entire hospitalization, improved quality, reduced testing and procedures. Successful PTN applicants will set goals for your PTN that are linked directly to those overarching national aims. You will be committed to how many of those aims your network would be achieving. We want you to be ambitious about the aims that you set, but we also want you to have high quality proposals that are going to succeed in achieving the aims that you set. A huge part of our evaluation will be looking for good value to the government. We want to fund proposals that have good aims and generate a lot of for the amount of federal expenditure that is made for those applications. Now, option year funding will be tied directly to your ability to achieve the aims that you've set. So that really is at the heart of this work. Continuation of funding in future years will be contingent upon producing the results that flow from your aims. Bullet on this slide. If I could move to the next slide. We see practice transformation networks as being responsible for really serving as the Sherpas, the on-the-ground networks that are supporting individual clinicians and their practices in doing the work of transformation for continuous improvement, culture change, bringing patients and families into the work. This is something that we do as part of the Quinn QIO program, something that hospital engagement networks funded by CMS are doing. It's transforming the way we do our work. When we bring the patients and families into it, it creates an urgency and a relevance that wouldn't otherwise be. We're expecting successful PTN applicants to have solid ways of bringing about patient and family engagement as part of your work. Of course, at the heart of improvement are using clinical quality measures and data to generate improvement and facilitating better practice management. If I could move to the next slide, I want to talk briefly on some, at another level of detail, on some of the themes that you've already heard earlier from Dr. McGann as part of his presentation. Applicants must demonstrate established data sharing capabilities. We want to build on existing infrastructure, and we want to use systems that are already present out in the field on the part of the PTN applicants. Now, we expect practice transformation networks at a minimum to provide aggregate data to the agency so we can see your progress in terms of quality improvement on each of the individual metrics that you specify as part of your proposals. That data needs to come to us quarterly. We expect, and I'll touch on this a little bit later, however, that you will be interacting and collecting data and sharing data back and forth with your participating clinicians and practices on a monthly basis. But the reports to CMS will be due on a quarterly basis. You will be accountable for making certain that all of the practices that you assist under this initiative are complying with applicable federal laws with regard to the data. Move to the next slide. So the question here, how will the Transforming Clinical Practice Initiative use measurement for results to achieve our quality improvement goals? As I had said earlier, CMS expects successful PTN applicants to have established systems and measures in place for collecting, assessing, and sharing monthly quality improvement data and results from participating practices. So successful come in and say, we need 3 months to build a system or 6 months to build a system. You will come in from to collect and share data from those practices that you're supporting. We will require ongoing reporting of key metrics such as population-based health improvement measures, quality indicators, cost, utilization metrics, patient-centered outcomes, and patient satisfaction. Metrics should be linked directly to the goals that we have for the and the individual goals that you establish as part of your application. Now, there is a table of measures that is attached to the funding opportunity announcement, and we want to encourage you to use those measures. They're not required, but our intention over time will be for all of the practice transformation networks to, over time, gradually migrate to the use of standardized core measures like those that are delineated in the measure table. If I could move to the next slide. We've talked already, I think the idea here is repetition and reinforcement. My background, so I'm not afraid to say the same thing over and over because it's critically important. And this business of having a measurement strategy that is in place and an ability from day one to collect data and share that data back with your practices and with CMS is critically important. You must propose your initial measures as part of your application. Again, I encourage you to look carefully at that measures table and use as many of those measures as you possibly can. And know that we're going to migrate to their use over time. We want to use, however, the kinds of systems that you already have and recognize that measures that you will be using, particularly in the initial stages of the work. Practice transformation networks and your participating clinicians and practices should expect to align your measurement strategy over time, again, with these. The summary of some of the details of acquisition and grants management, who will walk us through some of the specifics around the grant award process and other things that relate directly to the work of procurement.
Good afternoon.
Angela?
Thank you. First, we'll take a quick look at the grant-making process for this new initiative. Congress federal funds to HHS, and the Centers for Medicare and Medicaid Services is the agency's grant operation division for this new initiative. CMS Innovation Center program office that has planned and developed the 2 for this new initiative. The Office of Acquisition and Grants Management, OA, assisted the program office in the development of the funding opportunity announcement and processed the for clearance through the department and OMB and had it published on grants.gov. Staff and grantee staff has several roles and responsibilities. The grant management officer is federal staff at OAGM, is the officer responsible for the business management and other non-programmatic aspects of this award. She'll sign the notice of award and obligate the federal funds, and is authorized for the funding and terms and conditions of the award. The grant management specialist is also with a federal staff with the OAGM and will be responsible for the day-to-day grants and is the contact for the recipient when dealing with the grants related issues. This initiative will be funded with cooperative agreements, so there will be substantial involvement with us and the recipient. Program officer is the office official responsible for the programmatic and technical aspects of the grant, post-award monitoring, and reviewing the progress reports. The grant management officer, the grant management specialist, and the program officer will work as a team for these activities. The authorized organizational representative, the OAR, is grantee staff, is the designated representative of the applicant or the recipient organization, has the authority to act on the organization's behalf in matters related to the award and administration of the grant. They will sign and submit. The principal investigator is also a grantee, the individual designated recipient for the programmatic aspects of the grant and for the day-to-day management of the program. So the Federal Grant and Cooperative Agreement Act for federal assistance, grants, cooperative agreements, or contracts. A cooperative agreement is used when the principal purpose of the award is to provide assistance for the benefit of the public. So this new initiative will be funded by cooperative agreements. With the cooperative agreements, there will be substantial involvement with the federal government during the performance of these activities. The recipients can expect substantial collaboration by the Grants Office, OAGM, Program Office, in the management of these models. So here are a few of the program requirements, regulations, policies that will apply to this initiative and the cooperative agreements. As part of the effort to reform and strengthen federal grant making, OMB has published new guidance for all federal award programs, known as the Omni Circular, as you see it's referenced there at the bottom of the slide. This new guidance can be found at 2 CFR 100. This was published in December 2013 and it will be implemented on December 26, 2014. So this is the guidance that will be in effect for the duration of this new initiative. So I'll go over a few of the submission requirements. All applicants must have a valid employer identification number, TIN, or a taxpayer identification number, TIN. Both of these numbers refer to the 9-digit number issued by the IRS. All applicants must have a university numbering system, or DUNS number, in order to apply. This is a unique 9-digit identification number that identifies the physical location of your organization. And you can find more information at dunandbradstreet.com. In order to application, all applicants must be registered in the System for Award Management, SAM. You must have a DUNS number and an EIN or TIN number at this time to register. The SAM system combines several federal systems into one database. The authorized organization, AOR, that we talked about earlier, who will officially submit the application on behalf of your organization, must be registered in grants.gov and build a profile and have a username and password prior to submission.
Excuse me, I see a lot of comments coming in that someone is not on mute and the other listeners can't hear. So if everyone could just, phone is on mute. Thank you.
Okay, so all the instructions to enable a potential applicant to apply for this funding opportunity are contained in the published funding opportunity announcement at grants.gov. Today is the steps. Potential applicants refer to the funding opportunity announcements to ensure that you are completing all of the requirements. Please follow the detailed instructions that are in the appendix and section 5 of the FOA titled Application and Submission Information. You can access the electronic application for these models at grants.gov by searching for the downloadable application using the CFDA number. The application must be submitted in the required electronic PDF format at grants.gov no later than the established deadline date of January 6, 2015. Okay, some important formatting requirements. The applications must not be greater than 40 pages in length. This includes the project abstracts, project narrative, and the budget narrative. The project abstract summary is limited to 1 page and may be single-spaced. The project narrative must be double-spaced. This includes all components of the project. The budget narrative may be single-spaced. There are numerous charts and tables required throughout the project narrative components and the budget narrative. They may be single-spaced. And the font must be 12-point or larger. The AOR of the organization. The project summary is a 1-page abstract describing the proposed project found in the grants application package at grants.gov. You can select the project abstract summary and form. Again, this is a 1-page electronic form and it can be single-spaced. To submit the narrative, go to the grants application package found at grants.gov, the project narrative attachment form, and add a mandatory project narrative file. This file uploaded will contain components of the project narrative. Please refer to Chart 1 in Section 5 for these component descriptions and the rating points. You can also go to Section 6, detailed description of the components and the format recommendations. Budget narrative, you have to refer to the appendix, sample budget, and narrative justifications in the funding opportunity announcement for the detailed cost tables and breakdowns for each of the SF 424A line items and the narrative form. Again, these are located in the grants application package at grants.gov. So going forward, applicants are encouraged to submit a non-binding letter of intent to apply. These letters are due November the 20th, 2014. There is a link in the opportunity announcement to an online form that is submitted online. Again, you can view the funding opportunity announcement and the application kit and apply for both models at Gov. And these applications are due January 6, 2015. When submitted or after submission, you will receive an acknowledgement with a tracking number. After the application deadline, HHS will retrieve the application packages from grants.gov, and we will into Grant Solutions. Again, a return receipt will be emailed to the applicant's point of contact at that time. The program office, CCSQ, and grants office, OAGM, can have access to the applications, and we begin the eligibility review and panel review process. Upon completion of the review process, budget negotiations with the going to be a strong focus on the operational implementation of the models. The budget narrative must clearly break down of costs for the entire project period. Specifically, the budget narrative should provide detailed cost breakdown for each line item outlined on the SF 424A and the budget tables. As I mentioned earlier, these models will be funded with cooperative agreements, so there will be substantial involvement throughout each budget year of the anticipated 4-year project period. The anticipated issuance of award is 2015, and the anticipated period of performance is May 1, 2015 through April 30th, 2019. Final note, I'll mention that Grant Solutions, this is our web-based comprehensive grants management system that HHS will use to manage the full life cycle of Grant Solutions is accessible by the grants office, by the program office, and by the awardee. The pre-award stage throughout grant. Once funded, the awardee will receive an email from the grants office with a user ID and password for initial access to Grant Solutions.
Thank Angela, we appreciate that information. We are drawing near time with only a few minutes left in the call. We saw the questions were rolling in as we were viewing, and there are many questions, and we will get responses to those questions and post them, as was noted by Chisra at the beginning of this call. Just maybe to get in a few quick responses, and we'll go from there. Is one of the questions that came in, I was the Transforming Clinical Practice Initiative funding. I noticed that federally qualified health centers are eligible to apply for the funding, but also noted that the data will be captured through PQRS. Because FQHCs don't participate in PQRS, I'm wondering how we can participate. And if you know, and I'm sure to a number of other bodies, which is why we selected it, that it says reporting in PQ for those clinicians that are eligible. If you are not eligible, this would not apply. There are other requirements, obviously, that must be met, but this would not be one. Also saw a question come in about QIOs and whether they can be a PTN. Respond to that one, I think formally, but yes, a QIO can compete to become a PTN or partner or whatever the arrangement is through its corporate, just in the past for other federal funding opportunities. However, because CMS anticipates that there will be specific QIN, QIO accountabilities under the 11th scope of, then the QIO will have to make a decision about which role they will play for this new work, not for any of the other work in the 11th scope. And so maybe Paul, and take a quick question.
Sure, Jean. There was a lot of practitioners and rural clinicians, and you read one of the very specific FQHC questions, but there was a much broader one that I think would be helpful because I saw a lot of these questions in the chat box. The question and then our response. The question is, from our interpretation of the announcement for Transforming Clinical Practice Initiative, Practice Transformation, it is unclear if CMS would deem federally qualified health centers, health center controlled networks, and or primary care associations eligible to receive this support. That if they can demonstrate pre-existing relations with multiple clinician practices that include data sharing capabilities, they would be eligible recipients. Please confirm. And our response to that is yes, yes, and yes. Yes, and the questioner are encouraged to. Now you'll note in the applications and the FOAs that special attention has been given to small rural practices and those serving the medically underserved, and you can read a lot more about this on the Innovation Center website. This will be given explicitly in the last slide that Dr. Asamuga will go over as we complete this presentation. Dennis?
Yeah, thank you, Dr. Guillen and Jean. So here's another question, kind of a short question, but the answer is a little long, so I want to brace you for that one. This is regards who could be eligible, and the specific question is, would a Medicaid health plan be eligible for the following funding opportunities, the Transforming Clinical Practice? So here's the answer to that question, and again, it's a little longer because there are a number of conditions that have to be met by each applicant. So the first, participation in the Transforming Clinical Practices Initiative is available to institutions that are recognized as a single legal entity by the state where they're incorporated, have a unique taxpayer identification number, a TIN, designated to receive payment, are eligible to apply. Organizations must have a governing body capable of entering into a cooperative agreement with CMS on behalf of its members. PTN applicants must have pre-existing relationships with multiple clinician practices, primary care and or specialists that include data sharing capabilities, another one of the things that we talked about earlier. And applicants serve as medical professionals in specialty societies and organizations involved in generating evidence practices and guidelines for clinical practice, who promote measurement through clinical registries and electronic and are effectively incorporating safety in patient and family. Cooperative agreements may be awarded to public or private, nonprofit or for-profit organizations, institutions of higher education, other nonprofit organizations like faith-based or community-based organizations, and hospitals. Applicants must, or may be required rather, to provide proof of its status by submitting documentation. Evidence of eligibility includes valid Internal Revenue Service tax exemption certificates, statements from a state taxing body, state attorney general, or other appropriate state official certifying that the applicant organization has a nonprofit status, or certified copy of the organization's certificate of incorporation, or a similar document that clearly establishes that status. Now, we want to just note that this does relate to this about a Medicaid health plan, is that special attention will be given to those who are serving small and rural practices who are serving the medically so that's kind of a long answer because there are quite a number of conditions that relate to eligibility, and you would have to be able to ascertain that your organization meets each of those conditions in order to be eligible.
Great. So in conclusion, we want you guys to remember that the slides will be available online at the Innovation Center website after this conference, and that there's also links to the well for where you can find more information about the Transforming Clinical initiative, the Practice Transfer Network FOAs, that's a funding opportunity announcements, as well as important alignment networks. If you have questions related to acquisitions, please email them to tcpi@cms.hhs.gov. Again, that's tcpi@cms.hhs.gov. On behalf of all of us here at CMS, we want to thank you for your interest in this important work and your extraordinary efforts on behalf of patients nationwide. Thank you.
Tell us when we can say now. You sure?
Yeah, we're done?
I didn't hear the confidence there.
And we weren't on YouTube.